As Innes and Litwack explain, reliability refers to the probability or frequency of agreement when two or more independent observers answer the same question. For example, what is Mr. Smith's diagnosis? Is Smith dangerous? If representative pairs of psychiatrists interviewing a representative sample of prospective patients usually agree that each individual is or is not dangerous, the judgment of dangerousness is said to be reliable. Conversely, if pairs of psychiatrists would not usually agree whether such individuals are dangerous, that judgment is said to be unreliable. Validity, on the other hand, refers not to how likely psychiatrists are to agree about a particular judgment, but to how accurate their judgments are. If every psychiatrist in the world agrees that Smith would commit a dangerous act if released from the hospital, that judgment would be 100% reliable. But if Smith were released and does not commit a dangerous act, the judgment would be invalid. Similarly, psychiatric judgments of dangerousness would be generally reliable if most observers would agree whether or not given individuals are dangerous, yet generally invalid if those judgments usually would be wrong. Psychiatric judgments are likely to be no more valid and probably less valid than they are reliable. For example, if predictions of dangerousness are 50% reliable, there is only one chance in two that a second psychiatrist would agree with the first that Smith is dangerous. If psychiatrists cannot generally agree whether Smith is dangerous, we cannot be confident about the accuracy of any individual prediction that Smith is dangerous. Smith is either dangerous or not dangerous, schizophrenic or not schizophrenic. When psychiatrists disagree, when their judgments are unreliable, it is evident that at least some of them are wrong. The more likely psychiatrists are to disagree, the greater is the likelihood that an individual judgment is invalid. And this particular argument is of significant importance because the literature indicates that psychiatric diagnoses using these categories, that is, the broad diagnostic categories from the DSM-2, are not very reliable. According to Ziskin, the most common research findings indicate that on the average, one cannot expect to find agreement in more than about 60% of cases between two psychiatrists. The chances of a second psychiatrist agreeing with the diagnosis of a first psychiatrist are barely better than 50-50. The reliability of psychiatric judgments of specific diagnostic categories, schizophrenia, paranoid type, depressive reaction, passive-aggressive personality, and so on, as opposed to the broad categories listed in the DSM-2, is even lower, somewhere in the neighborhood of 40%. As Stuart Kirk and Herb Cutchins write in their 1994 article, The Myth of the Reliability of DSM, breaking down the numbers that were published alongside the DSM-3 in 1980 pertaining to reliability. Despite all the limitations of the data, DSM-3 was introduced to the world using the bold language of success. The actual reliability of DSM-3 could have been described more modestly as about what we expected, similar to previous studies. No worse than in the 1950s and 60s, and possibly somewhat better. Uneven, but promising, and so on. Evaluating a major 1992 study on reliability. 12 years after the publication of the DSM-3, Kirk and Cutchins conclude, despite the scientific claims of great success, reliability appears to have improved very little in 3 decades. Again, reliability is the problem the DSM-3 was said to have solved. And as Innes and Litwack emphasized in their own article, again from 1974, studies of reliability conducted under such controlled conditions produce higher rates of diagnostic reliability than are likely to be obtained in actual psychiatric practice. There, the lack of controls means that such factors as inexperienced or incompetent psychiatrists, particularized interviewing techniques and conditions, definitional ambiguities and biases, semantic differences, and so on, all contribute to lower diagnostic reliability. They also cite Pasiminek and his colleagues. Psychiatric diagnosis is at present so unreliable as to merit very serious questions when classifying, treating, and studying patient behavior and outcome. It is clear that psychiatrists disagree frequently on broad diagnostic judgments. They disagree more often than not on more specific diagnoses, and important consequences flow from the introduction in a judicial setting of one or another of the possible but unreliable expert categorizations. When issues of such preeminent importance as the right to liberty are at stake, the available evidence surely does not justify the abrogation of the traditional safeguards afforded by our legal system and the subordination of constitutional rights to a well-meaning but contrary to fact belief in the reliability of psychiatric judgments. Given the implications of this article and the total historical context of psychiatric judgments, I would not reference belief in such judgments as well-meaning.